afternoon, and welcome to Exploring IT's Role in Addressing Physician Workforce Management Challenges, a health system CIO production sponsored by QGenda. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the founder and editor-in-chief of Health System CIO, and I'll be your moderator today. We're looking forward to your participation. You could send in your questions or comments anytime in the Q&A box, and we will take them later in the program. Just so you see how we're going to spend our time today, first we're going to go about 35-40 minutes with our main panel discussion featuring Dr. Zafar Chaudhry, SVP, Chief Digital Officer and Chief AI and Information Officer with Seattle Children's, Kmar Hefka, Deputy CIO with RWJ Barnabas Health, and Dr. Patrick Hunt, Chief Medical Officer with QGenda. And then we will have our Q&A. So let's jump right in. Dr. Chaudhry, let's start with you, a little bit about your organization and your continually expanding role.
Hello, everyone. Zafar Chaudhry at Seattle Children's. We're a pediatric health system based in the Pacific Northwest. We have 46 sites across Washington, Alaska, Montana, and Idaho. And within that space, my responsibility is everything from infrastructure all the way through to digital health, and now the fun buzzword AI, and that's a team of about 500 people.
All right, very good. Thank you. Kay?
Good afternoon, everyone. Kmar Hefka. I am the Deputy Chief Information Officer for Robert Wood Johnson Barnabas Health System, a big, long name for the largest health system in the state of New Jersey. And I oversee everything IT that is on the ambulatory side. And a big part of that now is all of our digital health tools and the processes that feed those tools. We just finished, we have about 13 hospitals and over 400 medical group practice locations. We just finished a full Epic implementation, so we are one chart, one system, and just diving into what all that means for us for the first time ever to have all that data all together. Yeah, we're glad to be on the other side of that project, ready to move on to some bigger things.
Excellent. Thank you. Dr. Hunt?
Yeah, thanks, Anthony. Pat Hunt. I'm the Chief Medical Officer at QGenda, and prior to joining QGenda, I was the co-founder of Shift Admin, which is emergency medicine scheduling software. Clinical life, I'm an emergency medicine physician, still practicing a little bit, worked this weekend. And then I'm the Chief Medical Officer for all of acute care for Prisma Health, so covering emergency medicine, hospital medicine, anesthesia, radiology, and pathology for the Prisma Health system in South Carolina and Tennessee.
All right, very good. Looking forward to the chat. All right. How would you describe the current state of workforce management tools being used for doctors in most health systems? What role does workforce management technology play in promoting work-life balance? And how can poor processing or a lack of tools in this area contribute to physician burnout? I want to back up. I want to set the stage a little better here. And I want to talk about the issue of burnout, because this is all going to relate. Why are we worried about physician scheduling? We want happy physicians. We want physicians that are not burned out. And certainly scheduling is one of the ways that contribute to someone being happy and fulfilled in their job. If you can have flexibility, get off when you want to get off. If that's not an area of stress for you, that can be helpful. So I want to back up, and I want to ask all of you to talk about where we are with physician burnout and some of the IT related causes, and where you think scheduling can factor in on that burnout issue. Dr. Chaudhry, let's start with you.
Yeah, thank you, Anthony. So obviously what's interesting is that in most health systems, including ours, the systems we provide our clinicians, it's really a mixed bag. And because we've got systems that may not necessarily connect to each other, they're fragmented, some of them are outdated. I mean, most systems in healthcare are built on many years worth of old, outdated code. We're not necessarily providing our clinicians with the tools to do the job as easy as they could do it. And of course, most clinicians don't get into medicine so that they can work on IT systems. They get into medicine so they can actually have a conversation with the patient and provide great outcomes for the patients. So we've got to start looking at tools that actually focus on clinician patient time versus, oh my God, I have to, transcribe pages and pages worth of information just to process an insurance claim. So certainly in our system, yes, we have an integrated EMR, but other systems don't necessarily connect well together. We don't necessarily have a lot of automation and real-time visibility. And unfortunately, health systems, including ours, have started to focus on cost cutting more so than physician well-being.
All right, lots to unpack there. Well, let's go around the horn and get some other comments, and then we'll go back into that. Kay?
So very much like Zafar said, there's a lot of cost cutting going on, and but fortunately, there is a commitment within our organization to really forge ahead with some of the digital technology that we actually haven't had and now have based on our recent implementation. And I asked some of my very close physician colleagues before I came to this panel about this topic and about burnout, and what are the things, if they were sitting here, what would they say to that? How would they respond to that? And two things came up almost at the same time from both of the gentlemen that I was speaking to. And one was untether me, make everything as mobile as possible, and that will drastically improve my work-life balance. And then the second one was automate things that can be automated, meaning they don't need a licensed professional to get them done. And the more of those things that are kind of off the plate, the better. So automate the things that I don't need to deal with as a physician, and untether me. I love that term when they used it. Untether me so I can be as mobile as possible with everything I have to do to care for my patients. Now, again, I'm speaking from the ambulatory side of things, not the acute care side, but that's some of the feedback. And those are some of the things actually that we're concentrating on strategically now because of that.
That's perfect. Dr. Hunt, do you want to be untethered? You practicing? You were in the ER the other night. These 2 points, do they resonate with you?
I love that concept. And I think it's not just the ambulatory. I mean, I think as we, to Zafar's comment about AI, as we begin to sort of untether ourselves and begin to use the resources that we have, in a lot of it with AI and so forth, and being able to take, the phone to the bedside and be able to use that tool and do charting right there is going to, those are the things that I think are some of the biggest changes that we'll see from technology over the next 5 years. And, from my standpoint, every time we add new tech and so forth, people always, from the physician side, tend to be a little bit hesitant to embrace it. But I think this is one of those technologies in particular, and being able to have functional AI that really will improve the providers' lives and help with that burnout. To get back to your original question, the burnout piece, to actually help with that. The other thing I think that's interesting in the current our current environment that we have, the physicians that are coming out of medical school and residency now are very different than they were 25 years ago. There is a much more significant emphasis on work-life balance. And I think that plays a pretty big role in kind of how people engage with the health systems and also even engage with technology. And we sort of have to meet the demands of that population to solve the problem.
Dr. Hunt, talk to me about the relationship that physicians have with the idea of scheduling, or with the process of scheduling. Do you see how non-automated or non-integrated or a poor scheduling mechanism can add to the frustrations that are associated with burnout?
Yeah, absolutely. So, we always used to joke, if we had a department meeting, the two things we could get everyone to show up for is if we were talking about salary or compensation, or we were talking about schedules. because physicians, those are the things that really drive them to be motivated to, converse with the topic. Having a good schedule that allows you to balance sort of the needs of your life outside of medicine and hospital, as well as being able to, work in a way that you can make the living that you want to make, is really, really important. And that's kind of what we see with good scheduling systems. Having that ability to balance those two is critical. And in doing so and doing it well, you can avoid people that get frustrated with their schedules and say, you know what, I'm tired of working in this place that doesn't value me or doesn't value my time or my concerns with scheduling, and they move on, and that's never good for anybody.
All right, very good. Let's see what we got here. Workforce management journey. Dr. Chaudhry, where are you with this process? Are you in a good place? Are you trying to get to a better place? Um, Tell me about your workforce management journey.
So a couple of things we're looking at. First thing we're looking at is how do we reduce the admin burden on our clinicians? And so we have a task force looking at clinical notes and how we can start to standardize clinical notes so that people don't have to write pages and pages worth of information just to get things processed, because I think there is a huge discrepancy in that. The other thing we're looking at is, well, how can we assist clinicians in that documentation process whilst they're engaging the patient? So we're about to kick off ambient listening pilot in our clinics so that you do less typing, more listening, and more focus on why you actually became a clinician. And then the other thing we're looking at is we've set up a few work groups on the scheduling problem, right? Because referral management can be a disaster. We still have the dreaded fax machine, right? People are still faxing in referrals. People are still manually reviewing those referrals. Can we apply some technology that assists in that process? Can we provide more flexibility around that? And therefore open up some time, A, because we can see more patients, and B, people have the flexibility to adjust their schedules, do some shift swapping and flexibility, maybe reduce some on-call burdens as well for the clinicians. So we have a couple of work streams that are currently in play. And what we're trying to figure out is, well, which one of those will be successful in helping that particular process, and also ultimately leading to what clinicians need is more flexibility in their schedule so they can not feel that they're constantly overwhelmed with work. And we're also looking at this whole telemedicine situation, because in many health systems, including ours, we've actually burdened our clinicians with telemedicine on top of everything else they do. And we're of the mindset now that maybe we need to focus people and split that out. And that's what we're looking at as well, because you can't do everything. You can't be jack of all trades in a 12-hour shift, right? You've got to be able to focus on a certain number of things, and then you'll have more satisfaction at the end of that workday. So quite a few things. These initiatives are being led by my chief medical information officer to a greater extent, but we're partnering with the chief medical officer as well to try and see what we should invest in and what the result will be. And I know many health systems are probably ahead of us in this space.
How, Dr. Chaudhry, just a quick follow-up. Any insights into how you ultimately determine what you're going to move forward with? How you're defining success?
Well, I think success is based on how the clinicians feel, the ones that are participating in those work groups, right? Obviously, one of the biggest challenges in healthcare is a lot of administrators telling clinicians what to do. And I don't necessarily think that that's the best strategy. I think it has to be a partnership. So I, certainly from a technology perspective, can bring multiple solutions to the table, but it's got to be operationally, clinically led and IT enabled, not the other way around. I'm not trying to buy the next shiny toy that I saw at a conference either. So it's a multidisciplinary work group, IT, clinicians, operations working together to see what levers can technology pull, what changes in workflow can we enable so that the complexity of a patient pathway is reduced.
Mm.
And we also have in pediatrics clinical standard pathways. We're sort of the leaders in this space for many years. And those were like, hundreds and hundreds and hundreds of PDFs that our clinicians would have to trawl through whilst trying to take care of a patient. So what we've done is we've applied AI to those, and now you can actually ask the AI how to treat a particular patient with a particular condition, and it's very good at helping guide you faster and showing you the references so that you can spend more time with the patient. So sort of an amalgamation of pieces.
Excellent. Very good. Kay, you want to tell us a little bit about your journey in the space?
Sure. So I did reach out to a couple of the chief medical officers that we have in the ambulatory space and asked them to describe to me what they felt our physician workforce management journey was. And the reaction was rather visceral. What are you talking about? Workforce management. Physicians do not they're not managed. We're not a workforce, and we're
Oh,
not managed that way. We're not interchangeable, from
interesting.
a resource perspective. So I said, well, maybe we're just, a little bit screwed up with the semantics that Anthony provided.
Yes,
So
they
I
blame
blamed.
me. Yeah.
So actually, we had a really good conversation around that, and it turned into, well, workforce management definitely exists in our clinical space, but it's not necessarily the physicians. They benefit from it, but it's really everything that's on the periphery of that patient care center point, and that is the schedulers, the medical assistants, the case managers, the informaticists, all of those roles and teams that support our providers. And certainly we have workforce management in those on those teams. So getting past the visceral reaction of
Yeah.
what I asked them to talk about, and what we are doing very very consciously and strategically in helping with the difficulties that providers have had and are continuing to have, even though we're live on the one system. And that is, they wanted, just like Dr. Chaudhry said, let's pilot ambient clinical documentation. That would be a huge game changer. And so we actually are running, not concurrently, but we're running 2 pilots to figure out where we're going to land with that. But that is big. That has gotten a lot of attention. There's a lot of press outside, coming in for trying that. So we're doing that. We have a small pilot group, but wow, they love it. They absolutely love it. The second thing that we have done, given that we are such a large health system, but that expansiveness happened because of merging and because of buying hospitals and acquiring practices over time. And when all of those acquisitions happened, that came along a lot of workflows and processes and technology that was very disparate and remained very disparate until, from a technological standpoint, we put it all together. But from a management and a workforce and administration perspective, we did not. So there was no central scheduling. There was nothing even close to it. And over the last 2 years, we've put a big effort into making that happen. And that is redesigning schedules and, of course, automating a lot of the process. And we're making some headway, and we're getting there. And the response from our physicians in some of our key specialties, cardiology, orthopedics, in particular primary care, it's just, they love it. It's just amazing. So that was not a big hill I thought we were going to have to climb. Instead, it's a nice ski slope, and it's working really well. And then finally, yes, referrals. Oh, Really tough, really tough. Within even, within our organization, and certainly coming from the outside in, what we are working on now is providing education to our service line leaders, providers within those service lines, CEOs of our hospitals, a whole group of people, to make sure that they are aware of what I call our unified health tools that we have. We have at least 6 of them that are very meaningful. Some of them are Epic based, others are not. But we got to get our act together around how we use these tools, how we approach what's the best scenario for this tool for for this kind of interaction. So we're going through that exercise, and that's proving also to be very, very, very valuable in terms of just volume to fill the now cleaned up schedules. So it's coming together.
Excellent. That's great. Dr. Hunt, I want to ask you about something that Kay said, which is just fascinating. Um, the how the physicians reacted to, I guess, what they they felt like being talked about as a workforce that will be managed. They're very so you have to be careful. If you're an IT leader in a health system, you got to be extremely careful about how you phrase things, how you articulate things. We're talking about physician scheduling. They know they need tools to be scheduled and they have schedules, but they don't want to be referred to as a workforce that needs to be managed by other people. Tell me your thoughts on that.
Yeah, I was kind of chuckling when Gabe mentioned that. I have heard that before. I think a lot of it is nomenclature and what people, how they refer to that particular task. So, in the end, it's clinician optimization. You can come up with a terminology that kind of works, but the idea is that we want to be able to give the providers and the organization kind of the best of both worlds, where what we see is when you get schedules, particularly if you get centralized schedules, sort of what case they're working towards, and you have all of that information sitting in a single location, it makes things much easier from the standpoint of on-call information. So who is the emergency department going to call? They know that data, they have that data. I think maybe one of the biggest aspects, especially in locations that are really, fairly far advanced with the clinical communication tools, having that information tie in, because that has eliminated a ton of the workflow that we used to have in communicating back and forth as clinicians, because now it's all done via those tools, and it's quicker. People don't get interrupted with what they're doing, and you have kind of records of that communication. I think the one other thing that is, when I think about sort of workforce management and sort of the tools that we look at and provide, is actually related around truly capacity management. So, you have facilities, massive facilities with tons of staff, and how are we doing at optimizing the utilization of those actual physical assets? Whether, have someone who goes on vacation for a week, but we didn't get it set up right in the schedule, and now we've got, 2 MAs and 2 nurses that are there in this location and not being utilized the way that they could, or just the space. Oh, I don't ever work on a Wednesday afternoon, and that clinic space is available. And instead of doing that, one of our larger clients, they were looking at potentially building an entire new tower, and when they use the capacity management piece, they're able to optimize that. And so finding ways, we all have very constrained resources. So finding ways to utilize those resources as effectively as we can, and using technology to lever that, I think has been one of the things that we've seen be very effective.
All right, very good. Well, Dr. Hunt, you used the phrase having that info tie in. Dr. Chaudhry, you referred to silos. This is one of the biggest issues and challenges that CIOs are facing and health systems are facing. It's this push pull between what we'll call staying in suite, using what your EHR provider offers, and going out of suite when you feel it's warranted, and maybe getting some extra functionality from that unique one-off piece. But then you've got to tie it in. So, Dr. Chaudhry, where are you with this, working through these kind of dynamics? Usually, it's the CIO that will have more sensitivity to staying in suite because you're looking at the bigger picture, but the users may say, hey, this hands down, this one we prefer. And then a decision has to be made of cost benefit. So your thoughts, Dr. Chaudhry?
Yeah, so our policy is to try and stay within an integrated electronic medical record. But I'm of the true belief that you have to have the right tool for the right purpose at the right time for the right person, right? And you still have to work with the stakeholders. I don't think a digital strategy or any type of technology strategy, you as a CIO may have a say in that strategy, but I am here to serve my customers who are the clinicians as well as my patients and parents. I am not here to dictate what you should or shouldn't have. What I am here to do is to facilitate the conversation between the multiple parties to try and get to some form of the sort of 80-20 rule. Because, of course, not every single person will agree to every single thing. But if you can get 80% of the people on board with something that you're trying to implement that may benefit workflow, then I think you're in good shape. And I think you have to spend a lot of time outside of the technology realm, certainly in my shoes, to try and tell people that actually, do we really have the right process in the first place? Or are we just trying to put, lipstick on a pig? And that's what we don't necessarily do, because what we are looking at now as part of our optimization and scheduling is, well, what is the actual patient pathway in the first place? How many steps are we putting that patient through? And what we're finding is there's a lot of steps before the patient can actually get scheduled in the first place. And then we're asking the multidisciplinary group, well, does this make sense? Or are there areas that aren't necessary? Or are there areas that we can actually automate for you that you weren't automating before? Example being, if you receive an eFax, many people are printing the eFax to then do a referral review. And maybe you don't need to do that. Maybe we can take the eFax, summarize that for you using AI, and then you can say yes or no electronically, and then it goes on to the next step. And that will save time and also, well, it'll save a few trees, but at the same time, it should start streamlining workflow. So I think there's a lot of work that has to be done on the people process part, and we may not be doing that in every health system. We may be focusing on, well, I went and saw something really amazing and I want to put it in. And I truly believe the whole AI component is another tool in the tool belt to help us do things better. It's not a replacement of a series of things as it may be being sold by the technology vendors.
So, Dr. Chaudhry, quick question there. You're a physician, which gives you a different level of influence and credit with the clinicians that you're speaking to. And I'm wondering if you could have a dynamic, perhaps even for you, or certainly for a non-clinician CIO, where they're approached by users to bring technology to the rescue. And if you come back with, hey, let's look at your workflow first, they might say, I didn't ask you to look at my workflow. I asked you for a new tool. Why are you giving me a problem? I'm trying to get you to fix a problem. Do you understand what I'm saying?
Yeah, absolutely. And that's not an approach. So, first of all, my approach with my colleagues, albeit we may all be colleagues, isn't to tell them what to do. It is to ask the multiple questions. So, my first question would be, can we take a look at the workflow in collaboration with, here are the possibilities in technology, and here are the potential costs of those technologies? Because one thing people don't understand is, yeah, we can put in any technology. Any vendor will sell us something. But then how many zeros is that going to be? And you have to implement and sustain a new technology solution, otherwise you failed. So what we try to do is say, well, let's look at the two things in parallel and let's educate. So if you look at ambient listening, for instance, that decision that we made on a solution, we brought the multiple solutions to the table. We asked the question on, how do people think they want to use it? And then the group that we put together, mainly of clinicians actually, then did the workflow analysis, did the vendor meetings and briefings, and decided themselves what they actually wanted us to invest in. My job was only to make sure that we didn't go broke in the process, right? And so that's what I focused my energy on. But it was quite an interesting discussion to listen to, right? Because the questions that were asked of the vendors were the right questions that I don't think my team could have asked. I think it needed that clinical hat. So I think it's the job of the IT technologist is to facilitate the conversation, albeit it could be a heated debate at times, and keep patient and try to steer the ship. And hopefully the ship isn't the Titanic, right? That's what we're trying to do. I think on a daily basis, when you work in technology, you are a facilitator and a person who's trying to steer a ship. Sometimes the ship really does crash, and sometimes you reach the other shore successfully. And that's what I see my job on the basis being.
Excellent, excellent. Dr. Hunt, I'd like you to weigh in on this idea of in-suite versus standalone, and where we are with integration. If we choose something outside our EHR because we like the functionality, we think it's worthwhile. Where are we, do you think, in terms of, we've got different standards. We always want to, we hope it would be great to live in a world where this wasn't an issue at all, right? Ideally, this wouldn't be an issue. It would be like putting a plug into an outlet. It's all standard and we could use anything. We have total freedom and innovation would flourish, but we're not quite there. So your thoughts?
Yeah, so I think the first thing is kind of balancing. There's always oh, we could have this great new shiny toy versus what do we actually need? I mean, what's the important thing to do in terms of that integration? And then what's the functionality of that product? This is where you get back and forth between, products that are fully integrated or even part of the suite itself. And then outside products that may have a particular set of functionality that's not available in the other products. And I think it's a balance of what is the value that's being provided. We look like on the ambient AI side, we looked at same thing, multiple vendors, and realized that there are such different workflows that we can go in multiple directions with multiple different vendors to really solve particular problems, some of which integrate more tightly for particular needs and some of which don't integrate as tightly. And I think solving that particular problem is important. When I go back to the scheduling side and so forth, I think that's where having that tighter integration, because you've got all of those pieces of information flowing in and out from, whether it be credentialing, scheduling, on-call, clinical communications, there's a certain time where you need all of that information to be coming from a single source of truth. And then there's other times when it makes more sense to be more nuanced in the approach to get the right tool for that particular workflow. And I think that's a balance, I think, and I'm not a CIO, but I think that's kind of the balance a lot of the CIOs challenge or faced with is like, okay, when is it better to do something that is, more specific for a particular type of practice? And when is it better to say, nope, we're going to do everything for everybody in this one particular way?
Kay, your thoughts?
So we are the leadership in our IT organization, and we are over, as far as how big we are over 1,000 strong folks in IT. And our leadership of that, of which I'm a part of, is made up I would say almost half of us have come from outside the IT world. My boss, our corporate CIO, is a pharmacist, and I have a doctorate in healthcare administration, and there's nurses, and of course our CMIO. We're very into the workflow, whether it be administrative or clinical. So when we have a request coming from somewhere within an organization, and predominantly it is clinical, it always lands. It does land with us, I don't want to say we've educated, we brought along our organization in a really smart way to make sure that their first thing they do is to partner with us, to ask us, let's have a conversation. Because 9 times out of 10, as Dr. Chaudhry said, that it could be just a workflow issue that can easily be worked out. Simple is not disgraceful. It doesn't have to be a tool that fixes everything. So when we get them to the table, and we welcome the conversation about an outside and how we call it just an outside entity. There's some very basic things that we discuss, and the first one is it redundant to anything that we already have? It may work differently, but if it's redundant, it's off the table. Secondly, is that we have everything goes through a fit test and security assessment, no matter what it is, whether it's a device, software, no matter what it is. And a lot of things die on the vine right there, right there. And for good reason, and reason that the person or team bringing it to us will understand. And then if it does pass all of that, the last question is, all right, who's going to pay for it? And that is always a very interesting discussion, because that was not something that was planned to be answered. And that typically sends things to the back of the line too, when there's just no funding source for it. It was just hey, this looks pretty cool, let's see what we can do with it. So we're extremely methodical and careful about how we look at additions outside of our best of suite, because we are best of suite. And but we don't say no. We say let's talk about it. And the last thing I'll say is, again, our organization has been very well educated to engage us in that conversation very early on.
Yeah, and Kay, that's a great point. Users have to be educated on what the process is going to be, and so they come in ready. Like, if you're going to bring something, a request, you probably want to do your homework and have a certain number of things ready that will make it more likely that this will get further through. If you come in and just say, I saw a great thing at a conference, like, okay, right? We're too big. We have too many requests. So there's some education that you do with your users about how something might actually move, like a request might actually move. Here's what you need to come with.
Yeah. Oh, yeah. And well, they know the stopgaps. They're more familiar with the stopgaps than they are with the actual follow the process, because
Right.
they know they're there, and they know they have to stop in front of it and have it, have the fit test happen, have that conversation, the funding. They know that. So nothing's getting in without having those conversations, and they're well versed on that.
All right, very good. Let's talk a little bit about ROI. This relates to cost. You mentioned cost cutting being sort of in the air. We've got this interesting dynamic where costs are being cut, and Dr. Chaudhry commented how even though we want to improve especially the physician experience, we're being asked to cut costs. Ambient listening isn't cheap. Those licenses are expensive. CFOs want hard ROI. They don't want soft ROI. Sometimes that can be the best you can do with some of these things, to say, hey, there's some soft ROI here. This will help us keep clinicians, and here's what it costs to replace a physician. So it's kind of, we're putting them on the same slide next to each other. We don't know how directly they relate, and we don't know what's going to make the powers that be. What do they need to see? Dr. Chaudhry, what do the powers that be, the CFO types, what do they want to see in this environment when you're saying, hey, I want to get all these ambient listening licenses, or I want to get certain things because it'll reduce clinician burnout? What do they want to hear?
So I think in healthcare, and I've been in healthcare a really long time, everybody wants to get the benefit up front without investing the money in the first place, right? And most of these schemes are invest to save long term, right? So if you look at ROI, yes, everybody wants a hard cash ROI, but I would argue that mental health is an ROI. And we've got to make sure that our clinical staff remain sane and remain with us so that we can take care of the patients, because the patient loads, lots of people are sick and need help, right? So you've got to find that balance between, are we making an investment in a technology like ambient listening? And it may pay off, but it won't pay off on day one, and it won't pay off in year one. It will take some time for it to be implemented, sustained, rolled out, and then the benefits will start to come in. Because if you can get better documentation, you're going to get better claims put into insurance companies. That's going to increase revenue, and it's going to also increase where rejections happen, and you can fight back and get that claim actually paid. But at the same time, you really can't put a monetary value on people's health, and that's really important as well. So the burnout piece has to be addressed from the softer benefits, but at the same time, I think a happy clinician is probably a higher performing clinician in general. And, let's be truthful, doctors, nurses, allied health professionals come to work every day to try and provide their A game, right? They're not, this is not this, they're on the Super Bowl every day, right? If you're talking about Super Bowls, and that's because lives matter. So I think as a person in technology, as a leader in technology, whether or not I had a clinical background, my job is still to advocate for that invest to save model. We will invest, and this is what it will look like. I think we need to do a better job of articulating that in the business case, right? And clearly articulating what is a cash releasing, cash avoidance, improvement in outcomes, as well as improvement in the mental health of our employees. Outcomes is also very important. Patient outcomes is a form of ROI. Less people coming back to the ED within 30 days is a good outcome, right? As Dr. Hunt would know, because he probably sees people coming back because they didn't get what they needed the first time around. And I'm sure he doesn't want to see those people. He wants them to get healthy and never come back. So I think there's multiple facets to a business case. So we have spent some time streamlining and standardizing our business cases for investment in technology. And whereas the operations and clinical teams aren't necessarily good at writing them, we're very good at helping them write those. And then we become a true partner in the argument for investment so that we get the true benefit.
Very good. Dr. Hunt, make the case for this physician workforce scheduling. If you were talking to a CFO at a health system and you were trying to make a case for investment in this type of technology and they were giving you a little pushback, what would you say?
I mean, the first thing I'd say is, well, just the point. So, Charging K, I think no one has ever come to a CFO or CIO and said, "Hey, I want to give you this product," and it hasn't, it's doesn't have any ROI. Everyone is telling you that it's got ROI. It just everyone's going to do that, and so I think the part of that is what Dr. Charge is saying is really analyzing those long-term downstream effects and doing a better job of understanding that impact, because what is the impact of satisfaction on physicians and turnover, and what is the real cost? The numbers, you can read papers that tell you it's everywhere from $30,000 to $350,000 to replace a physician, and some of them go higher than that, and there certainly are real costs. But figuring those pieces out, I think we can do a better job of articulating that. I think the things that may be even harder to articulate are the things that really get to the patient safety, quality of care things, where we can look at those numbers, but it's a very poor metric to look at malpractice claims 3 years down the road because there's so many confounding factors. It's just hard to do that. You really have to get into the individual providers and kind of ask the question, do you feel like this technology is making you a more efficient clinician, a better clinician, a happier clinician? And those are the kind of questions. They're all soft because again, there's just with technology, there's not a lot of things that come in. You put them in place, and you immediately see this change in your cash flow right out of the gate. I mean, there's probably a few, but most of them, I would venture to say, that's not the case.
Yeah, and Kay, how do we, I mean, do we do surveys of the clinicians to say, hey, what are the top 5 things that are annoying you at your work? And then we say, oh, like 3 of them are related to IT, and perhaps one of them is, I can't get my schedule on time, and in terms of when I want it, as early as I want it, it's always wrong. Half of it's wrong. Like it's an issue. This is bothering me, and when I want to make changes, I can't make them. And it could be scheduling, or it could be it's something that ambient AI could solve, but I'm sure everybody's doing surveys of their physicians to find out, are you happy? If you're not happy, why aren't you happy? And how many of those have to do with IT? And the ones that don't, they're somebody else's problem, but the ones that do, is that how it works? Is that how we ultimately want to dig down into this?
It's one way
Yeah.
to get some insight, but it's in my in from my perspective, it's not the best way actually, because most of that feedback is complaining. That's and that's okay.
Yeah.
That's okay. There's a lot to complain about in the IT world when you're a care provider. But to gauge what physicians really need, what are they saying, um, and how can we respond to that? It does come with a lot of conversation, a lot of meetings, and actually, we don't meet. I don't meet necessarily with individual providers. I meet with service line leaders. And the service line leaders are the regions in our ambulatory space. They're very well structured, and they can put together a meeting with all of the decision makers and folks who get to the physicians pretty quickly. So we have a really, really good structure to be able to get some feedback like that for
Mm-hmm.
what specifically the service line is looking for, rather than more generality for, just throwing a survey out there. And once we figure that out, then we do some strategizing, and we offer some things, and ambient clinical documentation has been one of those, and centralized scheduling has been one of those. So we're lucky in that. This is going to sound really kind of backwards, but we're lucky in that we're in the beginning of developing maturity, a sense of maturity with a lot of the helpful tools that some of our other organizations our size have already had in place for a while. So anything new is going to feel great, and we're
Mm-hmm.
going to ride that wave for a little bit, but eventually that's gonna taper off. But we're getting some feedback, but it's not that doing it through a survey is not where we're really getting it from.
Okay. All right. Very good. Let's go to our Ask a Co-Panelist section. I'd love to hear what you guys would like to ask each other. Dr. Hunt, I'm going to give you the opportunity first. Do you have a question for one or both of your co-panelists?
Yeah, I think I'm curious. We've talked a little bit about it, but I think one of the things we see with regards to big initiatives is with ClinComs, with clinical communication tools, and I'm curious how you guys are managing that. How far are you down the process? If you already have a mature ClinCom strategy across all, or is it piecemeal?
Dr. Chaudhry, why don't you go first?
So we don't have, well, I think what we're seeing is that the noise in the system from multiple tools sending messages to clinicians is astronomical. Between the Epic in basket and 17 other ways of sending text messages, it is becoming very untenable. We did build a strategy to have a one mobile device centered communications program, but when we costed that out, it became somewhat cost prohibitive to standardize. So we're trying to go back to the drawing board and say, well, let's just tackle one of the big areas of noise, which is the in-basket itself, and maybe do it one step at a time because we can't absorb all of it. But I do think that for health systems, you have to have one device, one way of communicating, and everybody needs to sort of agree to that. That may be difficult, but and also integration is difficult because the other thing we found out, but it's got to be the ultimate goal.
Yeah.
Okay.
Yeah, one device that worked for us, is working for us, certainly. And a big campaign about PHI and the dangers of that in texting with non-secure phones, non-secure devices. We're doing okay with that internally for exchange from our providers that are colleagues internal to our organization. It's the external communication. Patient is out in the community with a doc who is not affiliated with us, who has no admission privileges with us, but the patient is coming here for a surgery, and that the exchange of that information either way is extremely challenging. And so that, I'm going to harken back to what I mentioned at the beginning, one other question that Anthony had asked, and our making sure that our provider organizations are very familiar with our communication tools, and we've packaged what they are together. We even made a game out of it. We call it Unified Communication Jeopardy, to see if just how familiar, here's your test. There's 7 things here, match it up to the thing they do. And everybody comes out of that going, I didn't know. And so the more familiar you are with the tools, the more likely it is you're going to ask to use them. But anyway, I'll finish up by saying the external communication, we're really latching on to direct messaging. I mean, that is becoming very, very prominent, from the out to in and in to out. Direct messaging is really becoming popular.
Excellent. Dr. Chaudhry, do you have a question for one or both of your co-panelists?
So I have a question for Dr. Hunt as Chief Medical Officer of a vendor that specializes in scheduling. How are you seeing the incorporation of AI in your tool to improve efficiency?
Yeah, so we have it on the back end, utilizing it with even algorithms to truly optimize. I mean, when you look at, we always think of scheduling, we always talked about it as it's basically a giant math problem. I mean, you have requests, you have shifts that have to be covered, you have providers that are available or not available, and putting all of that together in a cohesive fashion is a massive math problem, and computers can do that so much more effectively. And then sort of the next phase of that is, as we begin to look at schedules and see how people are trading schedules and changing schedules, can we take that data, ingest it, and then look at it to say maybe there's a better way to actually even build the front of the schedule and look at the capacity that we need to do and do some predictive analytics on, okay, what are volumes that you're expecting to see 3 months from now? So there's a lot of those tools that you can utilize. I think one of the things that QGenda's done a really good job of is not trying to get out over our skis and start saying AI, where a lot of vendors have said that, until we really have tools that are meaningfully impactful to our customers that can utilize that technology effectively.
Excellent. All right, Kay, do you have a question for one or both of your co-panelists?
Sure. Dr. Chaudhry, we're back to the ROI question. We have tried to do some of that with our ambient clinical documentation program, even though we're piloting. We were asked to show some sort of an ROI. So we went to pajama time. We went to, time for decreasing the time for clinical documentation. And we had big backlash from a provider group who was part of the pilot saying, just because we're decreasing clinical documentation time doesn't mean that that's how we can add more patients to my schedule. That's not the goal. So I'm curious about how, what's happening at Seattle Children's from an ROI perspective with that, and the pushback between administration and the providers.
So the approach we're taking is, I truly don't believe that we buy these tools so that you can see more patients. I think people are already overloaded with patients. And so we will show, and we are showing in our business case that yes, there is an improvement in pajama time, documentation time, and everything else. But one of our biggest pushes for the ambient program is focused around it's the cost of doing business because we've linked it to physician retention, physician recruitment, same for nurses and allied health professionals. And what I'm pushing in the organization is if we don't bring these tools to help our clinicians, we're going to lose these people. And it takes so many years to train these people, and they can go anywhere in the country.
Mm-hmm.
And if we don't do this, that's going to be the impact. And then if we do lose people, how much does it cost? So we've also factored in how much does it cost to replace a physician or a nurse with a specialty? How much money does that actually cost? How long will it take? We're finding to do re-recruitments up to a year. So you lose about a year's worth of salary. Then a new person comes in, they're not hugely productive on day one because they have to learn the health system and how it functions. So you could lose millions per provider if you lose the good people that you have. So we're sort of factoring all of those pieces into the discussion and the business case as to the selling points to the powers that be that only just look at the bottom line.
Thank you.
All right, very good. Let's go for a lightning round of final thoughts, 30 seconds each, no more than that. Um, Best piece of advice for someone trying to make their docs happy has a scheduling problem, has either manual, disparate systems, dealing with a lot of frustration, clinician frustration in this area. What's your best advice? Okay.
Use the term workforce management.
Now that's brilliant. You learn the hard way and then you blame me. They
It's
don't
my
want to be
lightning round.
they don't want to be managed and they don't want to be a workforce. How dare
Never,
you?
ever.
I love it. Dr. Chaudhry?
So I don't think we want to manage the workforce. We want to facilitate the workforce
Ah,
to provide the services that they really want to provide. And I say that one word of wisdom will be you can't talk enough with the providers. They have the answers. You just need to A, give them protected time to speak with you, and B, speak with them.
brilliant. Dr. Hunt, we'll give you the last word.
Yeah, I think we change it to clinician optimization, and in all ways, whether it's schedules or optimizing their time with their patients, so that, using ambient technology. I think that's probably a better way to do it, and a better term to use.
Yeah, and I love it. You can see one more patient is not a winning
No,
argument either.
nobody wants to hear that.
No, not at all. Brilliant. All right, wonderful discussion today regarding continuing education. You could use the final slide in this deck. You will receive an email when the on-demand recording is ready for viewing. If you want to work with us, you can reach out to Nancy Wilcox from our team and go to our website to register for upcoming panels. With that, I want to thank our amazing panel. It was a lot of fun today. Dr. Zafar Chaudhry, Kamar Hefka, and Dr. Patrick Hunt and QGenda for sponsoring, and you for attending. And with that, everybody have a wonderful day. Thank you.
Thanks, y'all.
Thanks.